So our next initiative was looking at the Thai-Burmese border with Burmese refugees and Burmese migrants that are escaping some of the oppression that particularly from 1988 till recently was endemic, that the government with their military juntas would target specific ethnic groups living along resource-rich areas, and they would displace them into Thailand. Thailand had not signed the United Nations High Commission for Refugee documents, so these people are not UN refugees. They are just people stuck in purgatory on the border. And they've set up camps, and they're managed by organizations like ADRA and other groups like the TBBC, but the UN cannot directly interact with them because they don't have that mandate. So they have to work through different organizations to deliver that. So they don't have the same clout. Now these people at the same time, because the government, the Thai government, has made a point of not wanting to sign this because they don't want these refugees in their country, there is a sentiment, particularly in the rural areas in Thailand, that these people are just mouths and hands to feed. That these the Thai villages around these refugees are just as poor, and they just as much deserve the assistance that the international community and the European Union are giving these people, but only the Burmese get the benefit. And that's the sentiment. Is it fair? I'm not one to judge, but these individuals are escaping military persecution, and they find themselves in a very difficult position. Of course, they've been there for 20-some years. They don't have any skills. They haven't gone to school. A lot of them are just living in a zoo, effectively, and they can't leave. They can't go home, and they are just hands and mouths that the government feeds. So we thought that we should give them skills to make them, one, economically sufficient, but also to find ways of engaging them with the local Thai communities. That if the Thai villages saw Burmese people needing raw materials, this was an economic incentive for them to work together and to start to bridge some of the cultural differences that they have and work on the financial incentives that come from that. So we developed a new stove technology, a high efficiency stove burner, because as some of you I'm sure know, refugee camps and internally displaced people camps consume a huge amount of natural resources, and they're a very potent deforestation agent, particularly in areas that are already arid or semi-arid. So these people come in, they consume firewood, they deforest the area, and all the environmental repercussions that come from that. And the cost of providing them with fuel is very expensive for the international community, and it's also an environmental burden. We came up with a stove technology that burns about 500% more efficiently than open flame burning, and we've been working with our Burmese refugee friends and with the international organizations that support them to create these industries. Just like we did with our water filter, we're doing the same thing. There is more of a political element here because we're trying to create crossroads to bridge the gap between these cultures and also to create opportunity through the economic incentives. It's so far been very well accepted, and but it's a very difficult area to work in because there's no road access, and it takes a very long time to get any resources. And at the same time, the politics of working in Thailand with the refugees is not the easiest. So some of our workers. Now, that's the technology-based programs that we run. But as an organization that prides itself on developing systems and developing more complex solutions to increasingly complex problems, we undertook two large programs, and this is currently our largest program, called the Kibera Medical Record Initiative. Now, how many of you have heard of Kibera? It's one of the world's Africa's second largest slum. It has approximately 800,000 to an estimated 1.2 million people living in geographically relatively small area. Some areas have a population density of approximately 25,000 people per square kilometer. And you contrast that with Canada's, which I think is 2.8 people per square kilometer. So a little bit more densely populated. So Kibera is an illegal settlement. And the government does not recognize them in a full citizen sense. And of course, they live in such densely populated areas without proper sanitation and without proper water that there is a huge burden of disease. And because there is no toilets, you will see walking through there, the ground is littered with plastic bags where people defecate in these plastic bags, and then they call them flying toilets, and they throw them to land on roofs or land on the streets. And so there is just a sea of plastic bags and sewage that flows from them, and children playing close to there or in those kind of bag collections. It's a very, very difficult environment to work in. That's probably the picture that I painted is how most impressions of Kibera have always been seen. I think they are some of the most intelligent, business-savvy, creative and courageous group of people that I've ever worked with. They rely on a very large number of interactions day in, day out. They understand technology and business better than most people I know in terms of how to capitalize on their cell phones, how to get maximum interactions, because to them, how many interactions they can have per day probably directly influences how much they're going to be able to make, what kind of food they're going to be able to provide for their families. So a very difficult environment to work in for a lot of reasons. But they've embraced technology in an exponential sense. The cell phone penetration in Kenya is seen at over 100%. That means that there are more cell phones than there are people, at least in the adult population. That means that some people have more than one cell phone, and you'll see all of them have a couple of SIM cards depending on the network, and they're using different SIM cards to maximize or minimize how much it costs and maximize their benefit. And so the airtime credit that they use to make phone calls becomes one of the most vital currencies. So we've hired people for airtime. So you get them to do a task and you give them airtime and they're willing to work with that. But sometimes they preferentially prefer to buy credit or airtime than to buy food or medications, because that creates opportunity for them. Rather than just getting food for one day, they're creating avenues to help support themselves. Now, that's a very challenging problem to face in a place like that. And because there are so many people, there's a huge burden of disease and many, many clinics that pop up to address that. But it's also, because there is so much disease, it's a great business venture. That clinics are, for the most part, privately run in Kibera, and they are, to varying degrees of success or ethics, they just run a little clinic. They tell people, come, we'll treat your typhoid, your malaria, whatever, at any level of diagnostic capability. Every one of these red circles on the map is a clinic in Kibera. There's probably close to 100 clinics for these people. But you can see they're almost overlapping each other. That you can't walk around a block or a structure without seeing a clinic in there. So I know a lot of organizations that have built clinics in Kibera. And the initiatives are and where you can get granting and money for, is to build more clinics in Kibera. Our opinion was that that wouldn't help at all. The problem is way more endemic than adding more clinics. So we thought what we would do instead was to link the different clinics together, and that we picked 7 clinics that we were going to network together in a phased program, And the way we would network them is with this daring idea that we would introduce electronic medical record systems. That instead of building a new clinic, we would create a software, we would provide ways for them to get computers, and we would network these clinics together. The reason that's important is because if I have a clinic and I have a lab in my clinic, and your clinic has an X-ray machine, people coming to me who are getting their blood work can have the blood work come out in the database, and you will send your patients to me and I'll do the blood work for you, and we share a database. At the same time, I would want to send my patients to you for x-rays because now we share a database that is both improving patient care but also creating new business opportunities and a referral pattern for people. So we've picked a platform called OpenMRS, which is an open source system. We've customized it to create our primary care electronic medical record system, and have picked a number of clinics to work with and are looking to network them. We have government approvals to create this whole infrastructure and to be a model for how e-health is done in Kenya, and to shape the legal framework for how EMRs, or electronic medical records, and the policy and the frameworks around that are going to be built. Now, on top of that, when we're collecting and connecting these clinics together, it's generating a lot of data, a lot of different diagnoses that are coming into play. So if I see 100 people that have in my clinic, and 10 of them have typhoid, or 10 of them have cholera, that might not mean much to me in a place like Kibera. But if those 10 people are all from one geographic area, they all live in this area, and all 10 of them have cholera, now that could mean an outbreak, or the beginnings of an outbreak. In a place as densely populated as Kibera, an outbreak is a very difficult thing to control, and it propagates like a wildfire. So you can see that with a geographic information system, which means we collect the data and map it on intelligent maps, we can start to see trends in HIV and cholera, in ways to target and fight tuberculosis, but also to shape our interventions a little bit better in terms of addressing vaccines, and that if a school or a district hasn't been vaccinated and a not-for-profit like the Gates Foundation wants to donate money, that we can create a structure for them or a system for them to deliver more targeted aid. That now we're not just throwing millions of dollars haphazardly at the slum, that there is a more integrated system that can target those interventions. Insurance is a bit of a optimistic and challenging pillar of our program, but by creating an electronic medical record system, we believe we can improve access to insurance. Now, insurance, particularly for health, is seen as premiums for a risk or a perceived risk. That if you as a young man are driving, you probably pay more for your car insurance than a young female of the same age, because we're demographically, everybody knows that we're reckless drivers. And so we get into more accidents. And so the insurance companies charge us a higher premium for that. And you can imagine a place like Kibera, when it comes to health insurance, are seen as very, very risky. So their health premiums are almost unattainable. People cannot buy health insurance in those places because it's too expensive. We believe that this intervention can, in a way, radically change the way we do health insurance. That when an individual is adherent to their medical care, that they go to the doctor, the electronic medical record can show that they're adherent to it. That if I have HIV, I'm going to seek care, and I'm less risky than I was when I first started. That for the first time, instead of paying more money to get healthier, by getting healthier, you'll be saving money. And that's the new intervention that we're doing. M-Pesa is that banking system I talked to you about, and we're using that in our plan to create insurance premiums delivery for these individuals. The last program that I'll briefly talk about is the latest one that we're launching, and is our Kenya surgery program, or our trauma program for East Africa. Now, Kenya in particular has 41 million people, They've been the recipients of donor aid for decades. And in terms of tertiary care hospitals, that means hospitals that are capable of handling big traumas. There's 2, maybe 3 tertiary care hospitals in the whole country. There's 20 intensive care unit beds for 41 million people. Now, to give you some perspective, our University of Alberta hospital, for adults only, they have 28 intensive care beds. They have just as many pediatric beds. They have approximately 20 neonatal intensive care beds. That's one hospital in one city. This is the entire country. They have 20 ICU beds. Now, by trauma, I mean injuries, so penetrating traumas, blunt traumas, so car accidents. And the reason we're talking a bit about this is because in my training, I'm in general surgery, and that's trauma surgery and trauma care, as well as surgical disease like cancer. Now, globally, if you look at the numbers, trauma and injury, leading cause of death worldwide in the first 4 decades of life. It's more than HIV, TB, and malaria combined. But all the attention that we get is on TB and malaria and HIV. Unfortunately, trauma has not been a big focus until recently. We believe that there are deficiencies in the surgical system, and those are due to cultural issues in the way people deal with traumas, particularly in East Africa. There's no financial support, but more importantly, there's no structural support. There's no road access, there's no ambulance systems, there's no ways to deliver that. But in my opinion, there is a lot of infrastructure in most of the developing world that is just being underutilized. That if you go, now I'll give you an example, that if you got into a massive car accident on the highway in northern Alberta, there would be, if you're very unstable, a plane or an ambulance would take you from where the accident is. If you're too unstable to come all the way to Edmonton, they would stop in Grand Prairie or Fort Mac, and we would stabilize you there. And those are very simple interventions, relatively speaking, just making sure you're breathing, making sure you're having some IV fluids, and once you're stable, you can proceed on to the tertiary care hospital. And that simple intervention of stopping somewhere and getting the appropriate resuscitation dramatically changes mortality. So everybody who's looked at that shows that there's a 50% improvement in mortality in places where there is a trauma system or trauma care delivery. Now, I think that the majority of the developing world has a lot of clinics that were built without any regard for urban planning or rural planning strategies. That if I know Father Joseph and Father Joseph has some land, I'm going to suggest that we build a clinic in Father Joseph's land. Doesn't mean that Father Joseph's land is the right place to build a clinic, but it becomes a matter of, I want to do something good with the best intentions, but I'm not looking at this transfer of technology appropriately. I'm transferring it the way I think it should be done, but not horizontally integrated within their system. These are the average roads in the rural parts of Kenya. You can see how difficult it would be to transport somebody, and there's also not really much ambulances. The trauma bays, this is the trauma bay at one of the tertiary care hospitals that we're talking about. This is what their high care monitoring is like. This is some of the suction devices. These are their stretchers. You can see that the laryngoscopes, which is the thing to open your mouth to put the tube to breathe for you, is locked, which I asked them if somebody came and you needed that, who has the key? They didn't know who had the key. So it's a bit of a problem. But looking at I'm going to have to speed a little bit. In terms of injuries, this is just for 3 months at this Moy Teaching and Referral Hospital that we're talking about. You can see that the majority, these are just traumas. Most of them are head injuries and lower limb injuries. And those make up the majority of traumas in East Africa. So our proposal is that if we were to map out all the clinics that are available in that part, in a 50-kilometer radius around that big hospital, that we could create a trauma system. That if you got sick within 50 kilometers of that hospital. We could take you, even with slow ambulances or bad roads, we could stop off in one of the smaller clinics, stabilize you, get you in stable enough shape to be transferred to the Moy Teaching and Referral Hospital. We're creating a trauma database to make sure that our numbers are showing that the intervention is beneficial, and we're looking at decentralization of trauma care. Instead of everything being done at the university hospital, that we're going to decentralize care to those peripheral hospitals to stabilize people. And we're creating a training program for people to, even individuals like people in this room who may not be from a medical background, can be taught how to do basic life interventions that can help. Or if they're people from medical backgrounds, there's advanced trauma life support, which are basic ways of approaching that. I won't talk too much about that, but I want to show you guys this map. This is a map. You can see all these dots. The rectangle in the middle, that's where the big trauma care hospital is. These are all the clinics that are available in a 50-kilometer radius. Now you can see, similar to Kibera, there is no lack of access to clinics. This is their level of care. 1 is the least level of care, and 5 is the big trauma center. You can see the yellow is 4. Those are hospitals. These are all hospitals. All the yellow ones are hospitals. But they're not being used for traumas. If somebody gets into an accident here, they would drive them all the way here. And that might take 3 hours, this short distance, because the roads are so bad. My proposal is stop here, stabilize the individual, even for 8 hours, then send them here, and they'll survive. This is just an aerial view, and you can see the rural parts of the country. Our partner in this is the Kenya Red Cross, and they've accepted the model, and they're going to be our implementing partner. And they've just acquired a whole fleet of ambulances that we're looking to use this geographic information system or the map to tell them that we should place these ambulances in all the yellow dots. That those yellow dots are going to be our new response centers. If somebody gets into an accident in that part of the world, we can send an ambulance to get them back, stabilize them, and then dramatically change their outcome. So it can influence how we allocate resources. We can improve the quality of life and security of these trauma victims, and particularly improve the services for trauma access in rural Western Kenya, and improve the level of care of all the facilities around the Moy Teaching and Referral Hospital. And more importantly, as an organization that creates models, we're looking to set a new standard for trauma care in East Africa. What the Kenya Red Cross wants to do is to make Kenya the model for the rest of Africa and the rest of the developing world, to look at this is a way of modeling trauma care, which is a problem that has eluded solutions for years and decades. We think that this is at least the beginnings of a solution. Thank you.
Perhaps you could clarify one thing for me. At the beginning of your talk, you talked about vertical and horizontal transfer of technology. And perhaps you could give us a few more examples of that, just to clarify what you mean. And hopefully, maybe some of the examples that you've used now, or that this IC change is doing. Because I think that was one sticking point. I've got more questions, I think, if I can clear that up.
Of course. Thank you for the question. I think that's probably the most important message in the presentation. Maybe an example can be vaccines. That if we were to look at the development of vaccines as a horizontal or vertical transfer. A vertical transfer would be, we research how to make vaccines, we create an industry to make vaccines, we package the vaccines together, and then we ship those vaccines over to Cambodia, and then in Cambodia they have a way of sending those vaccines to the right clinics to administer them. So that's a vertical transfer. We've done most of the academic and testing work, and then we've given that solution to individuals. But that leaves them perpetually behind this level of technology. They're not going to be able to learn to develop their own technologies. And I don't think that all countries and all places should do that. But when it comes to interventions like building an industry, looking at a water filter, we could have easily found a way of making these filters in Dubai cheaply and sent them to Kenya and just distributed them like the way mosquito netting is done. Mosquito netting is another example. I've used this example before in this class, but so permethrin is an anti-mosquito coating that gets put on mosquito nets, and people sleep under the mosquito bedding. So companies that make those in the developed world, and then they ship them to sub-Saharan Africa. I've been to the desert where those are needed the most, and what I saw was those bed nets were being used for chicken coop. So they'd use them to make fences, and chickens lived in those permethrin-coated chicken coops. Was that helpful? No. Did people understand why they were given this? They understood it to some extent, but there was no, by giving it out to them, there wasn't any kind of responsibility given to them to purchase it or to commit to buying this. At the same time, when the organizations that deliver these bed nets stop having any more stock, they need to rely on the Gates Foundation or the Clinton Foundation to supply them. So they have to send orders. Meanwhile, there is a big drought, more and more malarial cases. That I advocate that if we were to build an industry in Africa itself for making these bed nets, it would create jobs, it would create economic benefits, but at the same time, it would make people proud that this is a technology they've grown themselves, that they're accepting and they would use. And that's what we saw with our filters. We had another group come while we were working and supply water filters for free to 20 or 30,000 people in the area we worked. Some people that were working with us said, we're doomed. We're going to be out of work and our project is going to fail. I didn't think we would, because the technology that they brought was very advanced, very fancy, and they were giving it away for free. A few months passed by. The utilization of those filters, which were very advanced, was zero. The studies showed that they weren't being used. They were too complicated, and they weren't culturally appropriate. People didn't like them. Our filters, though, we did a customer satisfaction survey, and something we totally didn't think of, they liked the ceramic pots because they cooled the water. So as water slowly seeped through, it made the water cooler. And in a place that doesn't have refrigeration, they liked cool water. And we were like, I guess building it locally totally changed the way we work with these models. Does that clarify some things?
Absolutely, that was an excellent explanation. So then I guess to follow up on that specifically, a good example of a Westerner misunderstanding something is me misunderstanding the cost of one of these filters when you asked earlier today. So do you think that that's a really big problem, that the Gates Foundation and that Westerners in general just don't understand the cost of basic needs in other countries and the cultural implications? So is that a big barrier as well, in addition to everything else we discussed today?
I think that there is awareness, but maybe less understanding. That a lot of people, if asked, would say, yeah, there is X billion number of people that live below the poverty line, defined as $2 per day. People have that awareness, but like you said, they may not understand what that really looks like on the ground. That $2 a day doesn't mean that they're starving or that they cannot make do, but it reprioritizes the way they do things. That they can survive on $2 a day until something happens. And that when you come in and build an industry and you're like, well, that's so cheap. But understanding their fiscal restraints in terms of how much of that is going to the bare necessities, and understanding that they don't have a way of getting loans or using a credit card or a banking structure that allows them to save their money, that their money comes in and is usually paid to somebody that gave or lended them the money for the planting season, for example. So the cultural context of these things are paramount to designing a proper solution. But at the same time, I don't think the public can fully understand that until they walk a mile in the shoes of these people. That if we turn them into maybe US unemployment numbers or US household figures, and you told them that clean water will cost you this much, and you make $32,000 a year, and it will cost you $9,000 a year to get clean water. What would that make? What would that turn people? They'd probably say, we're okay, we'll take the dirty water. And then it becomes, how can you convince them to pay that amount? And I mean, look at health insurance. If you're young, you may not take health insurance because you may not think you need it because you're young and healthy until something goes wrong and you get into an accident. And then you have this huge bill that comes which totally reshapes the way your life was going to be.
Okay, maybe one last question on a more positive note. Do you have any examples where you saw unexpected innovation during any of these projects that you and your group didn't come up with, but that you adopted as one of the things that you did as part of the project from the people that are accepting your help?
Yeah, that's definitely a positive question, because it's, in my mind, it stops looking at the people that we're, and I don't like that word, but trying to work with, because I won't say help. That's too presumptuous. But the utilization of, how can I describe this? They call them merry-go-rounds. So our filters cost $10. People can probably save $1 a week. That what they did was women groups of 10 would every week would save money for one member. They'd pool their extra money and buy one individual a water filter. The following week, they would buy the next person a water filter. And that is born out of necessity, but the things that, while I knew that that was going on, the innovation was in how it made the community appreciate that intervention. That these 10 women became the pillar that others looked at. They're like, well, why would you support somebody else in getting this filter? They said, because it was important. And it created a culture that, it wasn't a culture of shame, but it was a culture of incentives, where people are like, I want this. And it wasn't seen anymore as a charity project. And that's what we've avoided marketing it as. We're not helping people. We're selling a health product that purifies water. People are proud of it. They walk around, it's all big and white and fancy and shiny, and they show it off. Then I saw, going to their homes, the way they treat the water filter. It's sitting on a table, covered in like a little drape, and to them, that's how we would treat our TVs. All right, I'm sure you remember at your grandma's house, she would have a little cover on top of the TV or like a vase on top to make it more aesthetic. That's how they treated these water filters. And they treated them with deference.
Okay. Well, I don't know if we have an absolute stop time today, but I think we probably should stop. So thank you very, very much. We appreciate your coming here. It's a very special, unusual day, and it's a special, unusual presentation. This is the third time that I've heard this, but I found it more inspiring today than the other two. So thank you again.
Thank you.